of you all. I am just going to show you some of the slides, some of the cases which will definitely come for your exams. It's only for clinical exams we are giving this talk. So, if these cases are there on the day of the exams, it will definitely be given as an examination case for you. So, we'll start with the first case. This, see, when you are presenting cases in the clinical exam, more than concentrating on the theory, you must tell whatever is reasonable treatment for that particular case. That way only we will be dealing with the clinical presentation cases. Not much of theory, but we want to know what you would do if this particular case comes to your clinic. So that is the way you have to go ahead in your presentations. Now if you see this case, you will easily say that this is a granular dystrophy because it's very typical. Individual small spots are there and spaces in between are clear. But this patient has got cataract. Now, the examiner will want to know whether you will do only cataract surgery or deal with the dystrophy also. Now, for this case, for this particular point, when you put the patient on the slit lamp, you must see whether the central part is clear. So, if the central part was clear, the patient would have had reasonably good vision even through this pinhole effect itself. So, if you remove the cataract alone also, he will be happy. Because as far as you can, you must postpone the keratoplasty as longer as you can. Because even in this particular case, what you will do is only lamellar keratoplasty. Even that, if you can postpone, it is better to postpone. Because when you are trying to do lamellar keratoplasty, there is a good chance that you may perforate the Descemet's membrane and you may have to do penetrating keratoplasty also. So if the examiner asks why you want to postpone even the lamellar keratoplasty, because the chances for rejection is less, even then you want to postpone. It is because if you can postpone, you have to do it because there is a chance for this case turning up as a penetrating keratoplasty. But if there were opacities in the center also, then you can say you will try for doing a lamellar keratoplasty and preferably cataract extraction also in the same case. And another question about DD will be about how to differentiate from macular dystrophy. This is a case where the patient has had opacity already, and on that there is a small ulceration. You can see the small. You can see the calcified spots. So this you have to mention. So whenever the calcified spots fall off, there will be ulceration in that area. So this is a case of atheromatous ulcer because the calcified spots have fallen off and ulcer has occurred in that area. Because there is a good amount of congestion which shows that this is an active ulceration. So what you have to do in this case is treat this ulcer part, scrape off these calcified spots, and then epithelialization will usually occur over that and the ulcer will heal. And after that, what would you do? Now, you have to, in all these cases, whenever we give cases of leukoma to students, they will say they will go in for PKP. That is not the answer always, because in this case, you can see that the pupillary area is reasonably clear. So, after healing this ulcer, what you have to do is find out what the vision is with this leukoma in place. Say the patient is having 624 or 618, you can leave the patient alone. And if the other eye is also normal, because most often if you do a keratoplasty when the other eye is normal, they usually are not happy because of high astigmatism and so many other things. The vision will not be that good and chances for rejection, so many things are there. So as I told you, even now, as far as possible, if you can postpone keratoplasty, you have to postpone. So, and another thing is, this patient he has got pseudo exfoliation also. We will expect you to tell about that point and find out whether the patient has got glaucoma. And then you have to dilate this pupil and see whether the vision is improving with that. Then you can even leave the patient with a slightly dilated pupil. And in any case of adherent glaucoma or oral glaucoma which is slightly off center, how to assess the patient about whether the patient will get back vision with keratoplasty is to dilate the pupil and see how much of vision the patient is getting, because the patient may already be amblyopia.